The human liver relies on a dual blood supply, an arterial inflow and a dominant portal venous system. Because different types of tumors draw from these two sources differently, we can use their hemodynamic signature to map precisely what they are. To do that, we evaluate a specific clinical pathway: how to diagnose, classify, and surgically manage benign, primary malignant, and secondary hepatic tumors. The baseline epidemiology for benign masses is straightforward. Hemangiomas are the most common, followed by focal nodular hyperplasia, or FNH. The malignant profile is different. Hepatocellular carcinoma, or HCC, is the most common primary malignancy originating in the liver itself. But the most common malignant liver tumor overall is a metastasis from somewhere else. Because secondary metastases vastly outnumber primary tumors, moving straight to surgery is dangerous. Defining the precise vascular behavior and origin of a lesion is the absolute prerequisite before any operative intervention. To capture that vascular behavior, we use the primary investigation of choice, the contrast-enhanced triple-phase CT. This chart tracks the flow of a contrast agent over time across 3 distinct chronological phases: non-contrast, arterial, and venous or washout. By plotting contrast absorption over these phases, we can map how a tumor feeds. A benign mass might absorb contrast slowly and peak in the venous phase, while a malignant tumor typically displays a sharp spike in the arterial phase, followed by a rapid drop-off. We classify these specific perfusion profiles using a standardized framework called LI-RADS, the Liver Imaging Reporting and Data System. The resulting scale dictates clinical action. LR1 and LR2 represent benign findings that require only observation. LR3 demands strict follow-up or biopsy. But an LR4 or LR5 classification indicates a strong suspicion or a definitive diagnosis of HCC. The triple-phase CT maps this hemodynamic proxy so accurately that a definitive LI-RADS 5 scan often supersedes the need for a physical core biopsy entirely. The most common benign finding is a hemangioma. These are vascular tumors found predominantly in females. They are almost always asymptomatic, though massive lesions can consume clotting factors and trigger Kasabic-Merritt syndrome, a dangerous consumption coagulopathy. On a simulated axial CT slice, the classic hemangioma signature starts hypodense, develops peripheral nodular enhancement, and progresses to homogeneous fill-in. Conversely, focal nodular hyperplasia, a hepatocyte response to vascular insult, is instantly recognizable by a prominent central stellate scar. FNH lesions carry specific markers. They lack a true capsule, and they contain Kupffer cells, which will light up as a hotspot on a sulfur collide scan. Despite these features, they yield a normal alpha-fetoprotein level. Both hemangiomas and FNH are generally safe. The hepatic adenoma is not. This mass is strongly associated with oral contraceptive and anabolic steroid use. It frequently causes pain and hepatomegaly and carries an approximate 10% risk of malignant transformation. The Bordeaux molecular classification breaks adenomas down further. Inflammatory adenomas carry the highest bleeding risk. HNF1 alpha mutated adenomas often present as multiple lesions. Beta-catenin mutated adenomas carry the highest risk of turning malignant. Because of the dual threats of malignant transformation and spontaneous rupture leading to hemoperitoneum, any adenoma larger than 2 centimeters requires surgical resection. Hemangiomas and FNH, on the other hand, can simply be observed. For primary malignancies, hepatocellular carcinoma is the dominant threat. While viral hepatitis and cirrhosis remain major risk factors, fatty liver disease is rapidly emerging as the modern driver of HCC. Clinically, patients present with hepatomegaly, but notably, jaundice is a late feature. They may also develop paraneoplastic syndromes, most commonly hypoglycemia and hypercholesterolemia. Returning to our comparative imaging matrix, we can see the absolute diagnostic hallmark of classical HCC. The tumor exhibits a sharp arterial phase hyperenhancement, followed by an early, steep washout in the venous phase. There is a distinct fibrolamellar variant of HCC that behaves differently. It occurs in young patients with non-cirrhotic livers. It carries a better prognosis, its AFP levels remain normal, and it is marked instead by elevated neurotensin B. In pediatric patients, the most common primary tumor is the hepatoblastoma. It almost always presents before age 3 and is closely linked to FAP and APCG mutations. Because pediatric outcomes can be highly favorable, aggressive surgery is justified, even though 50% of patients present with lung metastases. Finally, roughly 10% of primary liver cancers are intrahepatic cholangiocarcinomas. These are linked to primary sclerosing cholangitis and choledochal cysts. Unlike HCC, they present with early jaundice, normal AFP, and elevated CA19-. A primary tumor's specific molecular marker profile and the temporal onset of jaundice tell us exactly what we are dealing with. That data dictates the entire surgical and chemotherapeutic trajectory. The liver filters blood from the entire gastrointestinal tract, making it the most common site of metastasis from colorectal carcinoma. Roughly 60% of colorectal cancer patients will develop liver metastases. We can distinguish these secondary tumors from primary HCC by looking at their vascular behavior. In this CT comparison, the metastatic lesion remains completely hypodense across all contrast phases, lacking the hyper-enhanced arterial spike of a primary tumor. Managing these lesions requires a multimodality strategy. Patients undergo chemotherapy and biologic systemic therapies, frequently utilizing the anti-VEG agent bevacizumab to starve the tumors of blood supply. Historically, surgeons would only operate if there were fewer than 4 metastases. The modern mandate abandons that arbitrary limit. We now resect the metastases whenever it is technically feasible, provided the patient has an adequate functional liver remnant. That functional remnant introduces the core paradox of hepatic oncology. The oncologic stage of the tumor dictates the need for surgery, but the baseline cirrhotic state of the remaining liver dictates whether the patient will survive the operation. We estimate operative risk using the Child-Pugh score. As this scoring interface shows, a Class A patient carries a surgical mortality rate of roughly 10%. By the time a patient degrades to Class C, operative mortality spikes to as high as 70%. The MELD score evaluates risk using objective lab values, bilirubin, INR, and creatinine. Mortality rises 1% for every MELD point up to 20 and accelerates to 2% per point above 20. For HCC specifically, we rely on the Okuda score. You can remember its components with the mnemonic BATA: bilirubin, ascites, tumor size, and albumin. If the remaining liver cannot sustain baseline metabolic function, even a technically flawless anatomical resection will be fatal. These scoring systems serve as the uncompromising gatekeepers to the operating room. We map these variables using the Bailey algorithm. A patient with early HCC and robust Child-Pugh A proceeds to resection. If unfit, we check the Milan criteria. A single tumor under 5 centimeters or up to 3 tumors under 3 centimeters enables a liver transplant. For more advanced cases, we use local ablative therapies like radiofrequency ablation for small lesions. We use systemic therapy for metastatic disease, and we deploy arterial therapies like TACE or TARE to selectively cut off the hepatic artery supply to multinodular HCC. For resection candidates, we measure the future liver remnant, or FLR. An FLR over 25% is mandatory. Retaining over 50%. The core hemodynamic rule of this operation is that the most catastrophic bleeding originates from the hepatic veins. To prevent this, the central venous pressure must be maintained strictly below 5. Anesthesiologists achieve this extreme low-pressure state by utilizing aggressive fluid restriction and placing the patient head down in the Trendelenburg position. A right hemihepatectomy begins with wide exposure via a hockey stick incision. The surgeon divides the triangular ligaments to mobilize the liver, completely securing control of the hepatic pedicle at the foramen of Winslow, before isolating the right hepatic artery and portal vein. To divide the liver parenchyma itself, the surgeon uses a CUSA device. This ultrasonic probe vibrates rapidly to liquefy the water-heavy hepatocytes, aspirating the tumor tissue while leaving the denser connective vessels completely intact. Successful hepatic oncology relies on mastering this tripartite calculus, accurately reading the hemodynamic proxy on CT, calculating the patient's functional metabolic reserve, and executing the anatomical extirpation with flawless physiological control.